of Community Medicine at Government Medical College, Kottayam. And she has been an important person and played a pivotal role in establishing community-based palliative care. She developed a unit in Muhamma Panchayat and also an NGO. These have been in the Alapura district. Okay, and not only that, she has took all the effort and been an instrumental person in introducing palliative care into the community medicine curriculum. And because once it starts from the medical curriculum, then it will have a better role or better place to move forward. So in that front, and she has also been an important person in starting one unit in the Government Medical College, Alapura in 2009. And she has served as a first secretary of the Alapura initiative in palliative care. And she is also a member of the State Palliative Care Policy Team from 2022. And along with that, she has also completed her Global Fellowship Program in Palliative Medicine in 2023 from Pallium, India. With that, I hand over it to you, Dr. Sairu Philip, to take us through the session for today.
Thank you, Madam, for the kind words of introduction. Can you please share the slide for me from Pallium, India?
Yes, Sangeet will be happy. Are you happy to do it? Yes.
Yes, sure.
Thank you so
go
much.
Ahead.
Okay. At the outset, I should say that all the concepts and ideas presented in the following slides were internalized from the stalwarts in palliative medicine in Kerala and at the national level. And moreover, so ethics in palliative care was made interesting by the humanitarian perspectives of our dear Padma Shri, Dr. Rajgopal sir. Okay. So with that, we begin. So medical ethics, all of us have been taught about medical ethics, maybe in forensic medicine, or having worked in palliative care, we might have heard about it in different places. And when you think about medical ethics, it is a system of moral principles that apply values and judgments to the practice of medicine. When we practice medicine, certain things are very right, clear right. And there are answers which are clear wrong also. In those cases, the decision-making becomes very easy. But all of us know that in various clinical situations, more than one option may look right. Okay? And sometimes you do not know what is right and wrong. So this may lead to dilemmas. Another thing in palliative care and even in medicine, our ultimate objective is to preserve life and alleviate suffering. And when it comes to palliative care, as end of life comes, maybe our focus may shift more towards alleviating suffering than maybe preserving life. And maybe the boundaries, the boundaries between the two, all this can sometimes lead to dilemmas. Next slide, please. So we all know that the 4 cardinal principles of medical ethics: autonomy, beneficence, non-maleficence, and justice. Next, please. So when we say respect for autonomy, the thing is, we should think, what does the patient really want? Not what we think the patient wants, but what does the patient really want? The second thing is, does the family understand the patient's preference? These two can affect these two can influence autonomy, patient autonomy. And from our side, the pertinent questions are, whatever actions we take, does it directly or indirectly impinge on an individual's personal autonomy? Number 2, all the relevant parties, means whoever, the stakeholders, do they understand my action? Do they consent to my action? And more important, do we acknowledge and respect that others may choose differently? Or do we think that whatever we say needs to be obeyed? So do we acknowledge and respect that others may choose indirectly? All these are different tones for determining autonomy. Next slide, please. of us are familiar with informed consent. We all take informed consent for various procedures, various other things. So we know that in that there is you give information about pros and cons of the procedure or whatever. The second thing which we have to remember is for ordinary everyday procedures in palliative care, for example, like administering morphine, medications, consent is implied. You need not take informed consent. Consent is implied. For the routine things we do, like administering morphine, oral morphine, and maybe something beyond routine, there may be informed consent for those procedures. And again, we all know that written consent often becomes meaningless if the patient is illiterate, or if we do not actually convey to them, if they do not read the whole thing. So it is our responsibility to ensure, whether literate or illiterate, that every person understands the implications of the procedures that we perform on them. What we usually see is that the informed consent may be so long, sometimes the patient's relative may not really want to read it, or really cannot read it, small letters, so many things, so confusing. But beyond that, the real patient autonomy means they understand what they are told and they consent. Next slide, please. Beneficence. So that means what benefit? Do good. And the question is, whatever is the benefit, is it perceivable to the patient? And from our side, who benefits from our action and in what way? These are the things we should think in terms of this principle, beneficence. And of course, as said earlier, the physician or the doctor has an obvious duty to alleviate suffering, not only disease and cure. Next. Next slide, please. So as I said, when you think about the benefit, previous one, benefit is sometimes very subjective, okay? And physician's definition of benefit may be different from that of the patients. We may come across it in the next some of the slides. But then when you don't know whose perspective is, if perspectives are different, the cornerstone or the thing is, best option would be to go by the patient's definition of benefit. And for that, what should we do? How do we understand the patient's definition of benefit? How do you understand that? Can somebody unmute and say, how do you understand that? What the patients perceive as being benefit?
Talk to the patient.
Exactly. We need to talk to the patient. We need to converse with the patient. Next slide, please. So the best interest of the patients may be varied. Maybe to get cured, prolong life, preservation of function, life support, symptom control, end of life, maybe something other than this. And like Madam said, unless we converse with the patient, we did not really know what that person wanted to know. Next slide, please. So the second principle was benefit. And the third is non-maleficence, do no harm. So here again, the thought is, will doing the procedure or something, does it harm the patient? And maybe we have to think who all are harmed by our action. And in case there is some inevitable harm, what steps can we take to minimize this? And the most important thing, have we communicated the risk involved in a truthful and open manner? And if we have perceived there are some risks, have we tried to avert it or taken some measures to avert it? Next slide, please. Next. So like if it is a treatment, if it is something, intervention, does the treatment have any physical side benefit? Is it painful? Will it cause any physical disability, any emotional trauma, further social isolation because of that particular whatever action? Again, financial drain. Will it be a financial drain on the patient? And is the treatment congruent with the patient's goal? Okay. So these are the things we have to think, we have to reflect over in terms of harm. Next slide, please. And justice, we all know, have I identified all the vulnerable groups that may be affected by my action? Is my proposed action equitable? Equity, I hope we know. Equality and equity has got different connotations. Equality means giving similar to all. Equity means giving more to somebody who needs it. So equity, after the fair use of all available resources, means equity. And even though it is easy to say these things, in action, it may be really difficult, especially when our resources are limited and our needs are more. And I think I saw something flashing across the chat. Let me see. Can we, from Dr. Premnath, can we consider relatives' benefit if patient is not able to talk or unconscious? Okay. It depends, I think. Like, maybe if you have if you think that that relative is the surrogate decision maker, how would we know that? If we have good rapport with the patient even beforehand, and we know that this person is the surrogate decision maker, whom the patient itself may would have given the opportunity to take a decision, then it's a clear yes. But otherwise, I think it will depend on the context, depend on many other factors. So it depends, I feel. Okay, maybe Radha Madam or any other senior physicians in this group, senior persons involved in palliative care, can also answer to this query. This is what I feel. It depends on the context. It depends on the overall situation.
Can
Yes,
I,
sir?
madam?
Go ahead.
Yeah.
Dr. Yash wants
Yeah,
to
madam.
say something. And
Good evening, madam. Like in ICU, most of the times, patients who are critically ill, they lose mental capacity for obvious reasons. They are on ventilator, they are on sedation. In such cases, as madam mentioned, the surrogates of the patient, they take all the decision. So yes, beneficiaries can be decided by the family members, if the patient does not have the mental capacity. It is better that that person prepares himself for such things and gives an advanced directive or healthcare surrogacy, but generally not practiced in India. Ideally, every one of us should make a plan for ourselves. Otherwise, the family, the next of kin, has the right to take the decisions on the patient's behalf. Thank you, madam.
Thank you, sir.
Thank
Maybe
you,
one of the practical difficulties we face in our context is that the relatives may change often, like they may change often. In such instances, it can cause some difficulty. But as sir said, of course, the relative can decide on it. Okay, the next slide, please. Thank you, sir. Thank you.
Explaining everything. We can discuss about this, I think, at the end of it also a little bit more.
Okay, the previous one, yeah. So, like we said, is this a fair utilization of resources of the family, of the hospital, of the society, of the nation? So these are the things which we need to mull over when you think about justice. Okay, next slide. Next slide. And in palliative care, the 4 principles we talked of, it is common for medical ethics. But in palliative care, we know somebody who has fallen a prey to the long-term illness or threatening life illness, what happens? Or serious health-related suffering. For them, they're suddenly on one side of the wall. They're inside a dark room. The rosy world which they loved and experienced, it's now alien to them. It's something outside their window. So in palliative care, next slide, please. Lot more things are more important. Okay. Dignity of the person. Talking with full truthfulness and honesty. And unlike in our usual situations where some patients and even some, as doctors, we also are so familiar with that paternalistic attitude, doctors know best and the patients, they need to obey them. So, but in palliative care, everything is different. Okay. And there, the paternalism, more than paternalism, what we need to offer along with all those principles are principles of dignity, truthfulness, honesty. Next. Now, let me ask you one question. See, this is a person, I belong to community medicine and we do community-based palliative care. This is a person in the coastal belt of Alleppey, a lady with lymphedema. The question is just mull over. In our usual institutions, if she goes for an ailment, will her dignity be respected if she goes to a hospital in our current scenario? This is something which we need to reflect, because dignity of the person is something which many people would not have considered in our busy hospitals and all. Next slide, please. So how do we ensure dignity? By respecting the person. I remember what Rajgopal sir says. He says that every person in front of us is superior to us in one way or another. Just for the fact that the lady which we just saw now, what if we had a similar condition? Would we have tolerated it the way she is tolerated? Would we have, how would we have accommodated it? The simple reason that the lady is cheerful, she is living with it, with with much more complacence than, not complacence, with much more, a calm way than any of us, is a fact that makes her superior to me. Because if I had a similar like that, I don't know how I will take it. So I find that lady superior to me because she has been able to endure this health-related serious suffering with composure. So we should respect her for that. Similarly, every patient that comes her way, this I learned from Rajgopal sir. Again, the second one is the non-judgmental approach. Okay? The non-judgmental approach, maybe sitting in the hospital, we might have often heard about asking patients, why you didn't come early, why you didn't come the second time when I asked you to come back. Now, coming from the community, today morning I visited a place, a panchayat, a ward, which is in the same panchayat as my medical college. But in order to reach there, you have to travel 45 minutes. Then you have to go on a boat. Boat means a small boat-like thing across a ferry. And there are still people who have not checked their blood sugar regularly in spite of all the arrangements because of inaccessibility. So sitting in my hospital or my local OP asking her, why didn't you come early? It might be meaningless. So we need to have that non-judgmental approach just because we may not know the context from which the patient comes. We don't know it fully. And confidentiality, respecting the confidentiality of the person, of the disease, and person-centered care. Each person is different. Even though we see the same disease in many persons, for each person, it may be in a different way. So identifying that and our wanting to give a person-centered care, that will ensure dignity to all patients or persons. Next. So, ensuring dignity. This is a person, Harvey Churchino. He said, he explained what is ensuring dignity. So, ensuring dignity is treating a patient's severe arthritis and not knowing that his or her core identity as a musician. Okay, that would amount not ensuring dignity. Providing care to a woman with metastatic breast cancer and not knowing that she is the sole carer for 2 young children. Attempting to support a dying patient and not knowing he or she is devoutly religious. Each of these scenarios is equivalent to attempting to operate in the dark, or are some areas where we may fail to ensure dignity. Next. So Harvey Churchino, I think I should say one word about him. We all know the golden rule. We have been taught that please do to others as you wish others to do unto you. As you wish, yeah, that is your wish. How you wish to be treated, you treat others like this. That is the golden rule. Now he goes one step ahead. That is a platinum rule. And that is considered a new standard for person-centered care. And what does that say? Doing unto patients as they want done unto themselves. This simply means that sometimes you may think that you know what your patient wants because you want that. No. Try to understand what the patient really wants and then do that. That is a platinum. So doing unto patients as they would want done unto themselves. This is because, see, unless you or me, we have undergone the same disease, undergone the same serious health-related suffering, we are in no way eligible to gauge what that person wants. So that is the platinum rule. Next, please. So again, so patient or person autonomy now means right to have the information, right to have dignity, privacy, and confidentiality. Patient or person should be involved in decision-making, and hence the treatment decisions has to come as an informed choice of the patient. So in such an ideal scenario, when they have the right to make decision based on the information, based on everything, they can accept or refuse. So when they accept, it is informed consent. When they refuse, it is informed refusal. Next. So I wonder, there are many persons who may be working in palliative care. If you have undergone such a situation, you can share your experience. But what happens when somebody, you have informed everything, but they still have refused? What we say is the 4 dictums. 1, check their understanding. Are they really informed? Have they refused after that all the information have sunk into them? And we need to explore reasons why they refused. Counsel. And most important, the message for us is, if after all these 3, the person decides to agree or refuse, we have to support them. Yeah, I think one question came, like maybe like Madam said, after finishing this, we can take one question after the other. Okay. Next. So please put your questions in the chat. And partnership in care is, after all, shared decision-making. And in this process, the partnership is between the patient, the family, and the doctor. Next. So now we come. So far we have been talking of the 4 ethical principles, plus about dignity, privacy, confidentiality, truthfulness, which also has got a lot of importance as a principle in palliative care. And now let us think about ethical dilemmas. So what is ethical dilemma? Ethical dilemma is a conflict of moral principles when a person faces certain situations where adhering to one principle might violate the other. So this is where we feel we are in a dilemma. Next slide, please. So we come to a situation. Can one of the doctors please read it out for me? I would be very grateful. Please read it out to me, the situation.
Mr. R is a 74-year-old man. I hope everybody can hear.
Yes, beautifully. Continue.
With advanced cancer of stomach, he was a manual laborer, a devout family man who worked hard to support his wife and 5 children till 3 years back. Now all his children have started to earn. In his current state of illness, he refuses to take food and fluids. His wife and children are very sad and upset, thinking that when he has reached a state when they no longer need to stay hungry, but sit back and enjoy the fruits of his labor. He is unable to eat or drink. They are pressurizing the doctor to put an NG tube or give him IV fluids.
Okay, now let's discuss. So what is the dilemma here? If we were to encounter this, how would we handle it? Or maybe some people would have already handled certain situations like this.
So, Madam, we will try to understand what this gentleman, Mr. R, wants himself, what his decision would have been. And probably he is nearing death and this is a natural phenomena at the end of death. If that is the situation and he's in a mental capacity that he does not want, we should respect that. We should respect that.
Thank you, sir.
Thank you.
Any other suggestions? Or you can put in the chat and keep a watch with regard to this ethical dilemma. What are the principles which sort of conflict? Autonomy.
Beneficence also, I think.
Okay. Thank you, sir. Okay, any other, sir has given some points. Any other thing which any other doctors would like to share.
Madam,
And
may
you know, okay, please, Dr. Sujata, please.
it is the matter of dignity as well of the patient who may think if the concerned persons or family members are thinking to put an NG tube, we can go ahead with the trying of an NG tube and feed him till the end of life care.
Okay. Any other points? Any other points from any other doctors? So here, I mean, in our Indian culture, okay, the family is with the person. And you know, one of the biggest challenges for us may be to assuage the guilt of the relatives, in the sense that now they're feeling very sort of guilty, or they feel that he needs to have food and now see, he cannot have food. So what should we do? Like already sir and madam said. Next slide, please. Yeah, it is like you reported, it is a conflict between autonomy and beneficence. Next. Yeah. So respect for autonomy of individual patient requires identification of goals of care. So that's what Sir said, talk to the patient, understand what he really needs. So it could be cure of disease process, or it could be the quality of life. So based on the patient's values, we need to try to reach agreements about goal of care. Next slide, please. So maybe respecting the autonomy, when you say that, it means that you should not force feed him. Another thing which you have to ask, like Sir said, you have to talk to the patient. Talk to R and find what he really wants. Check his understanding of his disease. Why he does not want to take food? Why he is not currently taking food? Is it because taking food adds to his current discomfort? Or is there any other way he would prefer his nutrition? Is it because the current foods being given to him, he doesn't like it? He some way prefer some other food. So like you all said, it is effective communication that is required. Again, one thing, if there is anything correctable, that needs to be corrected. For example, if a person is very depressed, he may say, okay, I'm not going to take any more food. So you need to have psychological assessment to rule out depression. Next slide, please. So communicating with the person, exploring every concern, exploring every alternative, like maybe the frequency need to be in a pressure to feed the person. The family is giving too much of food, which he cannot handle. So should we decrease the quantity of food, or should we increase the frequency and decrease quantity? And maybe in course of time, he may reach a stage, or he might have reached a stage when he can no longer take oral feeds, even if he wants to, and is refusing NGT. Then we need to explore his fears of using NGT. Is he afraid of it piercing his other organs? We do not know. So in an empathetic manner, we need to talk to him and go by the decision of the person. So if he really needs an NGT insertion, and if he's not doing that, rightfully, we may feel angry sometimes and distressed as caregivers, caregivers, that is as a medical doctor giving care to them. But the thing is, keep the door open, go on communicating. Maybe in a few days' time, today he refused, but maybe in 2 or 3 days' time, he himself recognizes that now he has to have another alternative, and maybe the other alternative may not be as bad as he had thought. Maybe he will tell you, okay, doctor, I think what you said is right. Maybe I'll opt for that. Is there any experience, similar experience to any of the doctors? If you can share. Have any of you experienced any similar instances where the person refused, and then after a few days, after a lot of communication, he himself came, or she herself agreed? Okay, we'll go by the next slide. Okay, next, please. So who will read this second one? Second scenario. Can somebody read it for me?
Mrs.
Right.
M. Thank you. Mrs. M is a 97-year-old lady who is terminally ill. She is not responding verbally and now stopped taking feeds orally. Her family is pressurizing the doctor to give her feeds using NGT or IV fluids. How do ethical principles apply in this clinical scenario?
Yeah. So what is the dilemma here? How would we address this? Opinion from the floor.
Yeah. I think again, madam, autonomy, beneficence, and non-maleficence, all these three will apply.
Okay. So how would we approach the situation? Talk to the patient, say Soumya Siriya. Thank you.
Yeah. We first thing
But
is
the
communication,
patient is-
madam. Sorry.
But the patient is terminally ill, may not
Yeah.
responding verbally.
And then we have to talk to the family. What do they want for this patient? And we make the family also understand probably this is the end for this particular old lady. And if they understand, then we can probably skip if it is near death or death-like situation.
Yes, yes. Thank you. Again, from Dr. Sara, she says, counsel the family, true. Yeah, let's go. Anything else? Anything else in the chat? Let me just see. Counsel talk to the patient. Okay, thank you.
Just Dr. Cyrus, your ethical dilemma 2 itself is one of the question in the chat also, like something similar to that.
Yeah.
So I think
Yes,
that will be
yeah.
appropriate.
Yeah.
Dr. Aditi, no, justified
Yeah.
is it justified to treat a reversible cause of death like dehydration and terminally ill pain? Exactly what has come up in this. So I
And
think
refuses
that
to
chat question will also be answered when you go through with this.
Okay. Next slide, please. Okay.
So,
Like you said, of course, autonomy, beneficence, non-maleficence, all this can have tones on the scenario. Next. So beneficence. So does it benefit the person? One need to think whether giving fluids to this terminally ill patient, is it of benefit? Is it really dehydration? We think it is dehydration. Is it really dehydration towards the end of life when they stop drinking less fluids? Okay. And doing no harm. We have to think, see, our artificial hydration, does it harm terminally ill patients by causing circulatory overload, pulmonary edema, adding to secretions? And we should know that it adds to the distress of the person, even though the person cannot talk at this stage. Okay. From the family side, in a cultural context, caring for a person means giving them food, giving them lots to drink, making sure that they are getting fluids. So like you said, you need to counsel the family about the end of life care. How at the end of life, if you push on more fluids, it can cause more distress to the person. So when you counsel the family, the relatives would understand, okay, that they would come to your point. And again, like you said, if there is a real dehydration, a correctable cause or something, and if you want to give this thing, you can consider giving subcutaneous fluids rather than subjecting them to give IV fluids, taking them to a hospital during their terminal illness stage, and then giving them a lot of fluids, putting them in ICU. Okay. So that is it. Addressing the relatives' concern, you can always administer subcutaneous fluids at home also. So towards the end of life care, giving fluids when the person is not taking food or not taking enough of fluids, it may mean that at that point of time, that much of food or fluids may not be required. So counseling the family, taking them on board may be the most crucial thing. And of course, if for that patient, if there is something correctable, it can be corrected. Madam, anything more you want to add to this? Anything more you want to add from your experience, Radha, madam?
I see, basically, as you were mentioning, like all these queries, first explanation and doing few sessions, just not one session with them.
Exactly.
That is not, in these times, you may not have days. Okay, so it may be just like you can't do today, today. In a day itself, you can tell in the morning and give them some time to think. That's what is normally done when patients are very sick and things. So when you tell initially, for example, exactly what you said now, is this fluid going to help them or maybe harm them? And also we have to explain to them that at the end of life care, or not only because of any illness, even if it is just frailty, those type of patients also, the body may be closing down or shutting down. So those type of explanations have to be given. See the situation, explain. They may not be able to accept because, as you said, it is just the love and affection is showed like that. So once you tell them and give them time, just maybe half an hour, and then go back to them and talk to them and explain. So in that state, and then one more thing also can be said. These are medical decisions. It's not an affectionate decision because they all think, okay, am I doing something? As Dr. Sairu mentioned, no, many times it's a guilt feeling. For the first case, oh, my father did everything for me, but when I am okay and fine, I am not able. Yes, but is he in a state to accept all this? So dignity, empathy, then knowledge sharing, and then afterwards one more thing you can say, it is a medical decision. You are not making any decision in this. Overall, any patient in this situation will go through this, and with our like so many years of not only experience, there are statistics for all this. When someone is in that stage of their life, what are the harm that it can do? So another example, what in Pallium we always say is like parasite. Okay, sometimes if you see a tree and a parasite, see all what you feed, the parasite only will be enjoying, not the main tree. So like these type of explanations for them to understand easily can be given. And then the last thing was that your four questions in autonomy, what it comes, you gave, that were very nice. So they can adopt that, so that you say why the patient is refusing and then reasons. And then if even if we don't agree for autonomy, if that is the best thing, no, if that is what the patient wants, and there if it was you or me, if you don't get what you wanted to get, you're going to be upset. The same thing, your dignity we have to give for the patient also. So always in these ethical principles, initially when you look at the outset, it may be looking that there is some conflict. So what we say is risk benefit ratio, or you see the harm and benefit. You always have to see that which is overtaking. You have to do the risk benefit ratio and then finally make a decision. So
Thank
hope,
you.
I think because the queries which were there in the chat also, no, were somewhat similar to. Only one more last thing was there. Patient is not refusing for NG. No, patient is not refusing for NG tube. What is the problem in passing an NG tube? I don't know what Dr. Premnath wants to say in that. Sir, can you unmute and ask? So where if the to which
So in
case are
the
you
case,
put?
yeah, can I
Can
speak?
you yourself can unmute and say?
Yeah, I have unmuted. Am I audible?
Yes, sir.
Yes, we can hear you.
Yeah. See, the patient is unconscious, but patient is not refusing neither a nasogastric tube nor food or anything because he is unconscious. Relatives are insisting for the nasogastric tube to be passed. What is the question then? Is straightway patients be in interest or in
See,
the place of that
no,
patient's
in that
interest?
case, no, but there you have to see if it is for if the patient is terminally ill, or then you have to see they're doing good, doing harm. Those two you have to see. For example, if it is for the 97-year-old, just by her first explanation was, is this artificial hydration going to help the patient? Is the patient going to get better and get up, and that unconsciousness will get reverted by the IV fluid? Is that so? Those decisions, what was her condition, how was her deterioration, is her illness gone to a stage, everything has to be done. That is where her regular physician will play a better role. If she has been bedbound for 2-3 months and gradually becoming more and more unconscious and she's got to this stage, all those things have to be seen. And
I
No,
think
Dr. Sairu, you also can go ahead.
relatives,
Yeah, Dr.
patients'
Aditi
relatives
has,
advise,
sorry,
patients' relatives wish of keeping their whatever is the patient, grandfather, grandmother, whatever it is, and the doctor has to be contradicting, you want to send him off early by stopping.
No.
That is
So
the
that
ethical
there
issue.
is we should there's a response. We should also not be prolonging death with intervention. I think Dr. Yash has mentioned. See, exactly, this is what you have to see: beneficents and non-malfeasance. Both, all those have to be. And Dr. Sairu, you go ahead and explain.
Yeah.
You were about to.
I think, Madam, Dr. Aditi, who had paused that first question, has raised her hand. Do you have a question actually,
Yes, ma'am.
Dr. Aditi?
Yes, ma'am. Actually, I
Yes.
was in the exact same situation of ethical dilemma too. The only problem being that the patient had a bout of diarrhea, and then she became delirious after that because of acute dehydration. So now she was not saying anything. The relatives said, "Doctor, you decide what you want, what you think is correct."
Okay.
We tried to poke her with the needle. She because it was a reversible cause.
Yes.
She started resisting, so we stopped doing that. Now we decided that we will go ahead with end of life care and just respect her wishes. Most probably that is her wish, to not get poked at the end. After 1 or 2 hours in the delirious state, she started saying that she is hungry. She kept repeatedly saying that she is hungry. So now what is to be done in this situation?
If it is a correctable cause and if it is going to alleviate the suffering, that needs to be done. Okay. Actually, I think I got missed out 1 or 2 seconds. So I didn't get the middle part of your question. I heard that she had diarrhea and then I missed it. Then
She
I
had
heard that,
diarrhea and she became delirious because of acute dehydration.
obviously, then you need to correct the dehydration. Then,
But she wished to die for the past 5 years because she was bedridden and she was 97 years of age, 95 years of age. She wanted to die. Since the past 5 years, even when she was awake, she used to constantly say that I want to die. And I don't want to live this kind of a life.
Is Dr. Sairu still there?
Yes, ma'am. I think
Sangeet?
the audio is, I think, some net problem, ma'am.
We'll just wait for a minute. I think might be some internet issue or something. She's back. Maybe I think it says she's left. She might because of her connectivity. She might be going out and coming back in. We'll just wait for a minute. To thought.
Okay.
That's why I was telling them
madam,
that you might have had some connectivity issue.
yeah,
And you go
connectivity
ahead,
issue.
Dr. Sairu.
Yeah, I think Dr. Aditi, I hope madam, could you, or we can take it up towards the end, I think again. I'll just finish off my slides and then we'll take it up again. All I wanted to say it was correct the correctables and alleviate suffering. They should be our, alleviate the suffering of the person, distress of the person, whichever stage. Okay. Next slide, please. So dilemma 3, ethical dilemma or whatever, a scenario 3, case scenario 3. Who will read it out for me?
I'll do it, madam. 20-year-old boy with osteosarcoma of the lower end of the femur Now he has a large tumor size of a pumpkin, multiple lung metastases, and severe anemia. He wants an amputation now. You explain the risk to him, and he says he wants to continue with the amputation.
So what is how do we approach?
Madam, again, same principles, and the major thing is risk-benefit ratio or harm-benefit ratio in this, which I don't see any benefit, and probably the treating team should also convey him and the family that there is no benefit. And
Thank you, sir. Next slide, please. Next slide, please. Yeah. So every human being of adult years and sound mind has a right to determine what shall be done with his own body. Now, here is a person who wants it to be amputated. Okay. Next slide, please. So it is something, a conflict, autonomy, patient autonomy versus don't do any harm. Okay. Next. So the thing is, so the treatment that you're going to give, the amputation that he's asking for, what are the effects? Is it going to cause any physical disability? Will it cause mortality? Maybe if it does not cause, if it is a condition which does not cause any mortality, any emotional trauma, will it lead to further social isolation? Will that, not this, but then any treatment, would it be a financial drain on the person? Is the treatment congruent with patient's goals? So these are some of the things we always think while thinking about harm. Next. Next slide. Yes. What is the benefit? Will the proposed, just click 2 times again, then I think the whole thing will appear. Will this proposed intervention have any benefit to the person? Having amputated it, what will be the benefit? Will there be a phantom limb which is going to distress him further? Next. Next, yeah. What are his biological prospects? Will he get a cure? Will he get an outcome he wishes to? Will it prolong his life the way he wants? Will it improve his quality of life? So these are all questions. Will it take care of any distressing symptom that he has now, or does it go on to increase his distress? Next. So we don't know, we need to check the understanding why he said he wants this amputation. Okay, in spite of you explaining the risk. Again, why he's responding like that. So the reasons for the same. So like earlier we said, we need to counsel, we need to talk to the person, understand what is happening. And then, I don't know in this case, whether you can support the person. It depends. See, this is a scenario where the person is asking for amputation. And what if he is very adamant on amputation? Maybe you'll have to explain to him the mortality, the chances of mortality. Is he depressed? So like we said in the first context, we need to, ultimately it is to communicate with the person, with his caregiver, and to check that he really says what he means to say. Or if he really says, or do we understand what he says the way it is? He says, amputate my leg. Or is it an indirect plea for something else? We need to check out on that. Okay. Indirect plea for something else. Next. So maybe, like Madam said, if there is time, it is a long going process where you discuss with the person, his immediate caregivers, you explore each concern, you come to know more about it, you give time for them, again discuss, and then finally arrive at a consensus. Maybe it may not happen that way at times, like Madam.
I think there's some internet issue for Madam again.
Yes, ma'am.
Am I audible?
Yes, ma'am. Yes, ma'am. You're audible.
Okay. So ultimately, it is all about communication skills, competence, of course. About that amputation, I am no person to comment on whether the amputation is to be done or not. The surgeon or the person, the treating doctor would really, maybe you'll have to consult the treating surgeon and know their perspective. Is amputation okay for this person at this point of time? So that competence is needed from the expert. And counseling means communication skills, and that means actively listening to the person and understanding the genuine concern, being sensitive to the context, his personal needs, and of course, common sense. And as Madam earlier said, empathy, compassion, and that culture-specific understanding. Okay, all this has to go into when we talk to the person, we converse with them. Next, please. So maybe when we say about autonomy, respecting autonomy is not simply giving the person several treatment options. You say, okay, these are the treatments, and asking them to choose one option in a mechanical way. So the doctor should guide and explain to the patient, the therapeutic possibilities, the possibilities available, the odds for success. Okay. Explore the patient's goals, values, expectation. So all this need to be known before we give an answer. And this I have quoted or taken out from the Indian Primer of Palliative Care, whatever is written in the slide. So it ultimately means that unlike an MCQ where we can give a choice, you cannot say an answer unless you go through this process. Next. So shared decision making, as we were telling, it involves many things. One is, from the beginning, you communicate early, honestly, and regularly. As to how much you should communicate or how much you should break a bad news, that has got its own steps, which will be taken in another session, where you explore how much the person knows, how much the person wants to know, and then go step by step. But then whatever needs to be communicated should be communicated through that process, honestly and regularly. And clarify and be open to discussion with others in the field. So maybe you can talk to the surgeon, you can talk to the other specialist, find out their perspective, your team. So clarify whatever there is needed to clarify. And again, one important point we should remember is there should be, through this discussion, one of the best things I found in Pallium India is that morning, everybody, all those persons caring for the different disciplines, they sit together and discuss, which is very important, I feel, that multidisciplinary team meeting, where each one brings their concerns. So there is a lot of open sharing and communication. In our routine hospital setup, what happens? See, a person, you write a consultation, they come and see the person, write the consultation and goes off. You send in another consultation to another specialty, they come, write the consultation and goes off. But if you sit together, the perspectives can be understood and we can arrive upon a shared decision the ideal way. So clarify and be open to discuss with others in the field, consistency within members of the caring team, and balanced compromise based on ethical principles. We cannot always say, okay, this is always right in the situation, this is always wrong, something like that, because it always depends on the person characteristics and it can vary from person to person. Next. Okay. Now, case scenario 4. Shall I read it this time?
No, I will read it for you, madam. Thank you.
Thank you.
Mrs. F, diagnosed to have a malignancy, has been advised radiotherapy. She says, I do not want to talk about my disease. Just tell me what to do. What will you do and why?
What do we do here? She says, okay, I don't want to talk about it. Just tell me what to do.
No, we have to make her understand because she is the main person and she should take decision for herself, madam. We should make her understand the disease, the profit benefits.
Maybe in our culture over the years, I mean, some people are so used to this paternalistic move, Somebody decides for us, it is so easy for me.
Yeah.
Right? And we need to think, maybe why she's answering like this, why she says like this. Maybe she's too overwhelmed. She's too shocked about her condition, or she does not know. She feels she's feeling so, confused. Okay. So we need to explore actually why she talks like that. And if at all, At the end of it, she finally sticks on and says to you, oh, no, doctor, whatever you say, I mean, you just decide for me. Like I think madam previously told, no, the patients told something like that. Next slide, please. So again, autonomy and okay, beneficence. Next slide. Okay. So maybe you can tell if that thing comes. Okay, the person says, I don't know what to do. Doctor, you decided for me. You try explaining, you try talking to her. But then at the end, maybe you can try it in this way. Well, if I were in your position, I think I will. Okay. What if I ever? I think that is the maximum you can give. I don't know if you have any other opinions, please share. That is the maximum you can say in this context. You can say that if I were there, I would do this. Because this response I mean to give when, in spite of your repeated attempts to communicate and check the understanding to find out the reason why the person says so, in spite of repeated attempts and everything, you fail in that. And finally, you have to do something. This is the option. Anything else? Anybody wants to comment on this? Okay, if not, we'll go ahead. Next slide, please. Yeah. 4. Case scenario 4.
Mrs. Y is having advanced carcinoma cervix and is in renal failure. She presents in a state of terminal panic, restlessness. She was given parenteral midazolam to relieve the pain, restlessness. In few minutes, she dies. Is the prescribing doctor punishable as respiratory depression is a foreseeable effect of that drug?
Can you hear me?
Yes,
Okay.
madam.
Okay, thank you so much, sir, for consistently helping me out. What do you think about this? The other doctors, what do you think about this? In your opinion? Here, you know, the person, terminal stage, okay? End of life and terminal stage comes with terminal restlessness, okay? And we know that you have to give midazolam or you cannot relieve her restlessness. She would die in a restless state. She won't be calm. So you are forced to give, or you should give midazolam. And then she dies. Are you responsible? So what do you say about this? Could have chosen an alternative drug. What if, if the drug which is mentioned in the protocol is the same, okay? Think there is no alternate drug. Situations can come like that. Of course, if there is another alternate drug, it would be something similar to this group, may have the same side effect also. Decision taken in the larger interest of patients cannot be punishable. Okay, thank you, Dr. Premnath. Any other views? Okay, the situation everybody is clear, no? Not punishable. Yes, true. Have to take family in the loop. Okay. If the doctor had enough backup available, then not punishable by court of law. Thank you. See, the situation is terminal stage. And if you don't give midazolam, the patient will die distressed, very much distressed. So next slide, please. So here, why the scenario was put is to discuss the principle of double effect. Now, what is the principle of double effect? So a single act, there are 2 possible foreseen effects, one good, one harmful. But you have done it in good faith. You have given midazolam. Otherwise, the patient would die. Even otherwise, the patient is going to die. And then she will die with a lot of distress, that panic, that restlessness. Okay. And if it is done in good faith, it's not always morally prohibited if the harmful intent is not harmful effect is not intended. So you intended to calm her. You intended to relieve her of her restlessness and panic. And you have done it in good faith. So like most of you responded, you are not punishable. But we just wanted to introduce you to the principle of double effect. Next, please. So section 88 IPC, a physician is not liable for an act not intended to cause death done by consent and good faith for person's benefit. Example, use of analgesics in sick patients. Next, please. So the principle of double effect, as per the doctrine, so long as the intention of giving midazolam was not hastening death, the prescribing doctor is not guilty of the outcome, even if that effect is foreseeable. Okay. All that the prescribing doctor meant was to calm. Okay, next. Okay, the fifth one. It's a quite a long one. Should I read it, sir?
No, madam, you relax.
Thank you so much.
Thank you, madam. A 64-year-old gentleman with long-standing cirrhosis of the liver, admitted for GI bleed and severe coagulopathy. He developed hypotension, falling SpO2 and worsening renal functions, but the family wanted everything possible done for him. What do we do in such situations? Should we continue the transfusions? What about hemodynamic support and dialysis?
Okay. Anyone wants to comment? If not, we'll go to the next slide. If anyone wants to comment, you can. So the aim of treatment, okay, talk to the patient if possible. The aim of treatment is maximum longevity with the best possible quality of life. Okay. Sacrificing one for the other can only be done with the patient's informed choice. Next, please. So there is something, actually, Radha Madam had referred to it in the beginning. Benefit versus effect. See, what is effect? As doctors, we are so focused on effect. We like effects. So effect is a response to an intervention limited to improvement in investigation parameter or function of an organ. For example, the serum creatinine is 6 milligram and it has been reduced to 3.7 milligrams. Seeing that, we feel so happy, no? Sometimes serum electrolytes, somebody with hyponatremia, the sodium was previously 125. Now, when you look at it, it has become 130. You feel happy about it. But, or urine output increasing from 100 ml to 500 ml per day. We look on that effect. But benefit is the response which the patient has the capacity to appreciate. Benefit is something the patient doesn't know what exactly the implication of creatinine decreasing from 6 to 4, 6 to 5. For the patient, the benefit they perceive as, for example, an unconscious ventilated patient becoming oriented and ambulatory. Maybe just like Dr. Aditi mentioned, somebody who was delirious suddenly getting up and say, okay, I'm hungry. Okay, something like that. Some benefit is something which the person or the patient has the capacity to appreciate. So sometimes the medical professionals carried away by the effect may not concentrate on the benefit. And we have to be concerned about the benefit that the patient values. See, sometimes when you have a fracture, elderly lady having a fracture, maybe you want the fracture to heal, the fracture to get healed very, very perfectly, okay, from our medical point of view. But then for the patient, it doesn't matter whether it heals perfectly or not. What the person may require is her quality of life should be maintained. Her function should go on as before. Next slide, please. So futile care, that is what I was coming to. So goal of medical care is to achieve a benefit above a certain minimal threshold. But futile care is a care that fails to achieve that benefit. Okay. And unfortunately, a lot of futile care is in vogue around us. And physicians are not ethically obligated to deliver that futile care that in their best professional judgment will not have a reasonable chance of benefiting their patients. Okay. Next slide, please. So when you decide upon end-of-life issues, lot of things matter. Apart from the ethical aspects, there are modifiers, societal, economic, legal modifiers, and there are facts as well. Next, please. Yeah. And we know that these life-sustaining treatments, which are in vogue, CPR, mechanical ventilation, hemodialysis, blood and blood product transfusions, certain antibiotics when there is a lot of resistance and being in the ventilator, then and sometimes when you are on catheters, giving antibiotics based on the sensitivity, artificial nutrition via tube gastrostomy. So there are certain life-sustaining treatments, and that has become standard care. Next. So sometimes the perception of family is that, see, even in our setup, when somebody is ill, when somebody has become end of life, but still they feel that getting them admitted to the ICU is the best care. Okay. Or their neighbors or they themselves will have the guilt. Oh, I didn't do the best for my parents. So they've assumed that intensive care is the best care and demand it even for patients with end-stage diseases. Or believe it is their duty to insist that all means is used to extend their life, compromising the quality perhaps. Okay? And we should do everything to extend the life. And believe that the physicians recommend not to use LSTs only when they want more money or want to reserve LSTs for richer persons. These are some perception, not maybe universal. And they may feel that if they have not done all this, maybe later they may feel guilty that they have not done what they should. And also maybe their relatives will say that, okay, they have been very, they were not willing to spare money for their parents, something like that. Okay, next. But all these dilemmas, so these dilemmas have been there for many years, and there have been a lot of discussions and a lot of things coming up. And the National Cancer Grid, and they have said, you need not treat patients with advanced metastatic cancer in ICUs unless there is an acutely reversible event. So we have now, like Madam said, evidence generated that. See this is the link for 10 low value or harmful practices that should be avoided in cancer care. Unlike olden times, now you can choose wisely in India also. Okay. And people have now understood what are the things that should be avoided, which does not have any benefit or sometimes even effect. Next slide, please. And this is another thing. Guidelines for end of life and palliative care in Indian Intensive Care Unit, the ISCM Consensus Ethical Position Statement. So getting to know about this will help us to focus further. And all these dilemmas, which many doctors have endured over the years, there have been guidelines now. Next, please. Okay. So this is one I think I borrowed from Rajgopal sir. So for our class, sir put this question. Okay. Now let us read that question.
Mrs. X has advanced cancer and breathless. The specialist recommends intensive care for better oxygenation. She keeps saying, please don't take me back to ICU. Her son says, don't mind what she says, doctor. We want the best care for her.
So what do we do? I think we can have an opinion poll on that. What do we do?
We should respect her autonomy.
We should respect
her autonomy.
Her autonomy, yes.
Counsel
Anything
the
else,
family.
others? What is it, madam?
Counsel the son. Talk to the
Counsel the
son that
son.
what the patient really wants.
What the
And
person?
maybe.
Okay. Yeah. Benefit versus effect from Dr. Yash. Anything else? Yeah. Okay. What sir was trying to say was that like patient autonomy is there, but then unless and until you talk with the son and like explain to them or him and gets his consensus, the person for whose autonomy you worked may die peacefully without any distress, but then you will be held responsible because the son may otherwise file a suit, sir said. So all that he meant was that all these things, there are certain things like if it is a condition like dementia or something like that, long-term illness, we have come to the state where we need to write the advance directive, or there should be something like do not resuscitate, DNR guidelines. So all this will help us. But this scenario, sir, took to just remind us that in the current position, if you do not converse with the person, if you do not communicate and take the son on board, like you all said, he can take us to the court, even if we meant the best and we did the best and we did what was best. That the idea. Okay, next. Okay, respect the don't. Okay, the son may take you to the court later. Okay, Next. So what we were discussing is that there are still conflicts and limitations in the practice of autonomy. Should we comply with the patient's wishes, even if it would be harmful to him or others, like the person with osteosarcoma asking to operate? Can there be situations in which we should refuse to do what the patient wants? See here, the lady wanted to not to be taken to the ICU, but the son is adamant that she needs to be taken to the ICU. We must remember that an individual's autonomy is limited by what the society thinks is right. Okay. What if an individual wants to commit suicide and ask you for help? So there can be conflicts and limitations in the practice. What is it? I didn't get it,
There's
madam.
just some disturbance, I think. You go ahead.
Okay. Okay, next one, please. Next slide, please. So what we need to think is, see, ethics and law, the linkage between ethics and law. So we need to consider. It is possible that what is ethically correct may sometimes be legally wrong. Okay. And as citizens of a country, we need to respect the law despite our feelings of moral distress or conflict about the ethics of a situation. Okay. Euthanasia in India, it is illegal. Okay. And euthanasia is something which you do actively in order to decrease the life of the person. And it is illegal in India, although it is legal in some other countries. But one thing we should remember is that it is interesting to note that patients' requests for euthanasia are frequently withdrawn once high-quality palliative care is provided. Okay? And that is where we should focus our attention in India. So wherever the palliative care, we can give high-quality palliative care, these requests for euthanasia is found to decrease. Next. So maybe when we come to an ethics-based decision, okay, it's a four-pronged, four-quadrant approach.
Madam, when we come to an ethics-based decision, is someone wanting to ask something?
Yeah,
about euthanasia.
I will be finishing with this slide. Then we have 10 minutes for question and answer sessions. Okay.
And we have to do the case discussion also, please.
Yeah. So I am finishing with this slide. So four-quadrant approaches, see, you have to have considerations of beneficence. You have to have considerations of the expectation and informed autonomy, considerations of quality of life of patient, and also the contextual considerations. Okay. The considerations based on the context, whether it is legal, logistic, the policies that are available. Next. Yeah, that's what. So overall, what we were discussing today was the medical ethics principles with which we are very conversant, plus focusing on dignity, truthfulness, honesty, privacy, confidentiality, very important in palliative care, ethical dilemmas where these principles might be in conflict, but with consistent communication, person-centered care, compassion, we need to operate, tailor it individual to individual. Okay, there is no final, okay, this is the right, this is the wrong. Tailor it to the individual. Know more about the person, know more about his values, goals, know more about his family, their consideration. Take them on board. Then slowly things will get clearer than while we are talking about a hypothetical situation. Thank you. I think now it is time for all those questions. And if at all I have I have missed something.
Thank you, Dr. Sairu. What we'll do is we'll just take one question and then we have the case discussion also. Normally, that is the pattern. We will have a case. So, thank you very much for the presentation. And somebody was trying to speak. Can that person alone unmute and ask now?
I think that is Dr. Pushpa Kotu. I think some problem.
Okay, Dr. Pushpa, then unmute and ask, and then we'll go for the case discussion, Sangeeta.
Madam, I wanted to say something about euthanasia. That if passive euthanasia is given, that consent can be given, I think. Legally,
There's
it is
nothing
correct,
called as passive euthanasia
because
at all.
in case of Aruna Shanbag case, actually a lot of discussion happened during those days. I remember that very well. Ultimately, court gave decision to for consent for passive euthanasia?
I think in now we don't consider some passive euthanasia like that. Euthanasia is something which you do actively and deliberately to cut short to your life. But what we do in palliative care is not, you cannot say it as passive euthanasia. It is something different. It is something more, like you are alleviating the suffering. You're not unnecessarily prolonging life. Okay, you're not unnecessarily prolonging life and distress. Madam, can
And
you
you're
explain?
also not
Okay.
hastening. You're not hastening death.
Hastening
See,
death. Yeah.
you should not, those are the two important things. You should not hasten death nor prolong death. So both, you don't do something which will hasten death. At the same time, you should not do something which will so you do just supportive care and let nature take its time. So that is the
Passive
difference.
euthanasia is in other words, it is we are not prolonging life, isn't it?
See, that's all. See, as I said, no, understanding it properly, and you are doing only supportive care. You don't, for example, you don't give something which will stop respiration. So the dose, everything matters. For example, even midazolam, if you give 10 milligram midazolam or 1 milligram midazolam. So we don't give 10 milligram midazolam. There are strict protocol and guidelines for how much dose to be used. So, as I said, no, there are strict guidelines for usage of drugs, and these are all not one person's decision. These are all made by a group of physicians. Like for India, see, Madam is one of the member of the policy making. Means like that we have full members, neurologist, anesthetist, psychologist, not one or two. It's a board of members of 15 to 20 people. Legal members are also there in that. When we do end of life care, this topic will be dealt also. And then at that time also, we will go in more detail. When end of life care is, we will have a session on end of life care, Dr. Pushpa. And in that also, it will be said, generally, euthanasia is active process. There is nothing called as passive, but your query, like on that day when we do end of life care session, we will talk about it also. There is something called as withdrawal of treatment, withholding treatment. There are many, many terms like that to it. So there are many aspects to it. And so it is not passive, it is an active process. That much I can say. And then there are strict guidelines and protocol for doing the even sedation, everything for end of life care.
Thank you. And
Okay.
remember, our job is to increase palliative care. Make sure that palliative care is there, high quality around. That should be our motto, and wish you all the best.
So we'll go ahead with the case discussion, please.
Good evening, one and all. Am I audible?
Yes. Go ahead.
Yes. I'm going to present a 74-year case of 74-year-old male who is who's with advanced CA with unknown primary and multiple metastasis and generalized lymphadenopathy. He came with presenting complaints of swelling over the left side of the neck for the past 1 month and pain over abdomen and right hip for the past 20 days. The patient was apparently normal 1 month back when he noticed a swelling over the left side of his neck, which was initially small and gradually increased in size, for which he was admitted and workup was done. During workup, excision biopsy was done on 16/4/24, and he was diagnosed as a unknown primary with multiple metastasis and generalized lymphadenopathy. Patient now has complaints of pain over the right hip region and abdomen. On describing the pain over the hip region, the onset is for 20 days. He has a constant aching type of pain, which is radiating to the back. There are no any associated symptoms. Movement and sitting for a long time are aggravating the pain, and the rest seems to lessen the pain. And the severity is NRS score 10. Numeric. The significance is the patient finds it difficult even to use the washroom and is anxious to attend nature's call. Pain over the abdomen, the onset for 20 days. It is intermittent, dull, aching type of pain. There is no radiation. He also has loss of appetite, loss of weight. He has complaints of constipation and difficulty in micturition. Food intake seems to aggravate his pain, and analgesics, he is ready with analgesics. Pain in the abdomen is moderate with a numerical rating score of 6, and pain is more during daytime. Patient does not have any other comorbid illness. He does not have any history of fever, breathlessness, or chest pain. He's a smoker and an occasional alcoholic. Sleep disturbances are present. The pain in the hip region bothers him a lot, and he's having insomnia for the past 10 days. On examination, patient is conscious and oriented. No icterus or pallor. Temperature is normal. Pulse rate is 78 beats per minute. 20 breaths per minute. Respiration is 20 breaths per minute. BP is 110/70. Saturation is 98% in room air. Is respiratory and cardiovascular system examination was normal. Abdomen and other system examinations were normal. Next slide, please. Significant investigations. RBS is 81 milligram. Urea is 18 milligram deciliter. Creatinine is 1. Total bilirubin is 0.5. Direct is 0.2 and indirect 0.3 milligram per deciliter. Sodium is 136 milliequivalents. Potassium 4.5 milliequivalents. PH hemoglobin of 11.4 grams per deciliter. Platelet count of 2.36. And ECG was within normal limits. CT chest showed lung metastasis in bilateral upper lobe, bilateral posterior basal segments, and in the right lower lobe. There were also metastases seen in the D8 vertebra. The right adrenal, both adrenal glands metastases were there. The largest one in the right adrenal, measuring 3.8 into 2.5 centimeter. CT abdomen showed para-aortic lymph nodes, thickened bowel loops and stomach with inflammatory changes, and bilateral adrenal metastasis. In PET CT, there were metabolically active supra and infradiaphragmatic lymphadenopathy. Multiple lung nodules were present, bilateral adrenal mets, and cystic lesions over the right iliac crest, and T8 vertebral cystic lesion was present. Treatment: the patient was given tablet morphine, 10 milligram 4th hourly, tablet paracetamol 500 milligram TDS, tablet domperidone 10 mg BD, ranitidine 150 milligram BD, and bisacodyl 5 milligram 2 HS. The patient was initially suggested for having a right lumbar sympatholysis, but he refused for treatment, and he preferred only oral medications. Psychosocial aspect. This person is a 74-year-old elderly person. He is fully dependent on his wife, 70, who's also elderly, and a cardiac patient herself. His 2 sons have abandoned him, and only his daughter is providing money for their expenses. He doesn't want to bother his daughter and son-in-law further by admission and special care for him. He also feels he has become a burden to his wife, as she is the one helping him in his day-to-day activities now. He also doesn't want to live anymore and only to have a peaceful death. He doesn't want admission and trouble. The main concern in this patient, how we manage the pain of the patient, because he had severe pain in the hip region, and he's in advanced stage of cancer with the unknown primary. And how are we going to give palliative care for the patient? And the patients are also having lack of monetary and emotional support from his family. Summary: this is a 74-year-old patient with unknown primary, with multiple metastases and generalized lymphadenopathy, who came with complaints of pain over the right hip and abdomen. Discussion: the pain and the palliative care for this patient has to be addressed. And in the medical ethical aspect, the patient refuses to treatment. Actually, the patient did not initially want the lumbar sympatholysis, but we explained it to him, and we emphasized him on having lumbar sympatholysis. So we were in a dilemma. I was in a dilemma if this is correct. If it bothers the autonomy of the person, if we should have only increase the dose of morphine. But eventually, after he accepted the treatment, and we gave him lumbar sympatholysis, and his NRS score reduced to 6/10, and also psychological support to be provided to the patient, since he's deprived of emotional support and monetary support from his family. And he actually, patient came only with his wife and a neighbor. We wanted to convey this to his son or daughter, but the patient refused it. So will this hinder with the confidentiality? Actually, the neighbor was ready to give the details of the children, his children, but the patient doesn't want to bother. He's very frustrated with his sons and doesn't want to bother his daughter. So will this interfere with the confidentiality, or is it our duty to convey them and explain it to them? Thank you.
Dr. Sairu, you can go ahead. Sangeet, can we come out of this presentation so that everyone can participate?
Okay, ma'am.
Is Dr. Sairu still there, Sangeet?
No, she has left.
Okay. Okay, no worries. Thank you, doctor, for presenting this case. See, the main concern, no, like anybody wants to go ahead and give your opinions. Go ahead, and then I will add on more. Okay. See, the main thing is that providing pain relief. That is the symptomatic care is quite important. Okay, for that, here, the main thing, no, first find out why is he refusing treatment. And our job is to explain to him by the procedure. For example, no, palliative, we have palliative radiation, palliative anything. So palliative, all modes of treatment are there from palliative point of care. So from pain relief point of view, we have to explain to Dr. Sairu, are you, like we just lost you. So that's why I just started explaining.
Yeah, it's okay. Actually, the network is, some error is
Okay.
there.
So
Madam,
in
you
that case,
continue.
I'll go
Madam, you
ahead and then you can add on, or you want to start off.
Madam, you continue, please.
Okay, so basically, so providing palliative care is important, means pain relief is one of the important things. So first, either initially you can sit and talk to him and explain to him the modes of pain relief. Okay, you have oral intervention, non-pharmacological, everything. So, and then his intensity is so high. So some, as the interventional method may give better relief. So first we have to explain everything to him. As I said, giving time is not days. You can give him time. You can come back to us evening or tomorrow, and then make a call and then see. And she said that you explain to him and also find out why is that. See, some psychological, psychosocial, emotional, all reasons are there. That's why again and again we say everything total. So total pain, total care. So in this, you have all the components there. So you have to sit and find out what is that is making him not go there. If you have the facility for having a psychologist in your team, utilize that facility. Okay, so that, see, a doctor per se, many of us are trained in those also, that is, but still you will not match a psychologist. So, and we also have psycho-oncologists nowadays. So if you have the facility of having someone trained in that specialty, get their help also. So that might help you to find out why is he refusing to approach his family. And finally, if that is his decision, we have to see. See, today we have seen so much of importance. There will be dilemma or conflict between the ethical principles. But every time you do the risk-benefit ratio. Okay, if you're going to totally wreck his emotion and then go meet his son, Is that so? But if you give time, and then he may say, okay, you can tell this to my son, or tell not everything. So some compromise can happen when you make the decision or discussion with them. So you do the risk benefit and then see and do the best for it. Always everything is patient centered. What can I do to improve the quality of life of the patient and the caregiver? Here the wife also is there. The wife is going to be the surviving person. So you have to explain everything to the family, to the wife and him, explain the risk benefit and see what best can be done and move forward. And I think whatever intervention you did and gave some benefit was, you would have seen the response and benefit in the patient. And
He's able
doing
to
palliative
sleep
care.
now. Yes, ma'am.
See, exactly. So, and then get the help of psychologist and add on more things. What were the other concerns? Pain relief, and then you said this. Anything else you want me to explain? Please go ahead and tell Dr. Nancy.
No, ma'am. He defers any admission as such. Can we continue palliative care even in advanced
Yes,
stages?
home. I was about to say, then this is the right stage where home care will be helpful. So if, I don't know whether you have the facility, like a nurse or a social worker can go to his home, find out, then see once his NRS came down, then you can manage him with oral morphine. He's able to swallow?
Yeah, that he's able to do.
Yes, very good. Then continue with morphine. Go titrate the morphine dose as per his need. Give laxatives, give antiemetic as per the protocol. You all had the morphine prescription session. So do all that. Follow up and get his pain under control. He may even be able to mobilize and do like his personal ADLs, days of the activities of daily living. So there are so many patients whom I have seen just with morphine, they'll be able to do things within the house. So it will be a big difference. Once you break that very severe pain, once they get to mild to moderate pain, they can manage and they'll start doing things, and that will raise their morale. When they can do their daily activities without getting help from others, it will improve. And Dr. Yash had his
Yes, madam.
hand raised,
Yes, madam.
so you can go ahead, Dr.
Good
Yash.
evening, madam. Madam, two doubts in this case. One thing is when we have an unknown primary, is our approach to palliative care same as, because we do not know the outcome of that disease, now if it is an unknown primary. Does our approach to patient like palliative care wise changes when the primary is unknown, or is it the same?
But if it is unknown primary, you have to see the staging of the disease next.
Okay.
You have to get the help of the oncologist. Because that's why multidisciplinary team
approach
and multimodal management, these are the two core things. As I said, no, psychology, oncology, radiotherapy. Even you have so many palliative radiotherapy options. So you have to have an oncologist, psychologist, and a social worker, pull all team together, and then look at then multimodal management.
Thank you, madam.
Okay, and unknown primary also you have to do staging, which will give you an idea on that. You get the help of the oncologist. Dr. Sairu, I think she wanted to say something. Go ahead.
Yeah, I just wanted to say how Madam beautifully explained the concept of total pain, the emotional pain. The caregiver, have you talked to the caregiver? Like, because the person doesn't want his children to know, the caregiver, maybe she might feel overwhelmed looking after him alone. So it would be beautiful to explore the reasons why with him and with the caregiver alone, what are the, what you call the undercurrents between the father and the children? Maybe that might itself cause him some emotional pain. So if it is something which can be taken forward and rectified, maybe that should also be explored. Talk with the caregiver. Maybe the mother would like her children to come and help her in this situation. But then the father does not want it. Why is it so? Is there something which can be rectified? Maybe it has to be explored, like Madam says, with a specialist psychologist who can help us in this matter.
I will, if there's no other question, I'll give one small case example itself for this. in a minute what we have had. Is anybody else wanting to ask anything, or the doctor who presented, have I clarified all your queries? If that is okay, I'll just take a minute and explain this case, what happened in reality. That might help you all.
Yes, ma'am. I'm good. I got clarified.
Okay. Thank you. Okay, I'll just tell you one case, what exactly happened. It was a father who was like a daily wage person. This was in Pallium few months ago. And he was very sick. It was only like 3-4 months. It was again some disease identified nearly only in stage 4. So only radiotherapy was suggested. He went for radiotherapy, but within 4th or 5th sitting, he became more sicker. So they said he's unfit for radiotherapy. And that is when it was one girl who was looking after the father completely. So that girl, mother, and father, patient, wife, and daughter came to Pallium. And the mother, really was a housewife who did not know anything else. So this one daughter was doing everything. So within a week or so, he deteriorated so badly, and he was getting to a stage where he was not speaking, not doing anything. So at that stage, this girl had not even informed her rest of the siblings and the patient's siblings, everyone, no one was told. So he was deteriorating so much, though that morning, we got the daughter, started speaking to her, and we told her, if he deteriorates and dies, and if nobody knows, she will be the person who will have to face the whole family and her siblings. So fortunately, that morning we took her to our side. We, psychologist, nurse, and myself, we all three spoke to her. And at the end of it, she started crying. And then she herself said, I think it is better that I will go inform everyone. So we said, no problem, we will help her. So we just started communicating, because the patient's siblings also have the right to know things. So, and within 2 hours, everyone came in, because they were all only there. And then I think all this happened in the morning, and that evening the patient passed away also. But she was so, when as soon as everyone came and all that happened, she had 2 brothers. And the patient's siblings were also there. So sometimes these things, they may have some inhibitions or some difference of opinions. So she was about to go tell, but that was restricting her. Just that discussion we had for half an hour helped her to open up. And she herself, after that before going home, she came and told us. But what we could see, the benefit that she also got, because she also was doing everything on her own. So like that, as you do and see patients, you will see the benefit and things.
Thank you, ma'am.
Madam, while I was in Pallium, India, I was deeply impressed by the way that trivial things which others may consider trivial, like talking in this matter, talking to the daughter, taking time off to talk for half an hour to the daughter. Okay, those things are given a lot of importance there, and it matters also. That's what I wanted to say. These things which may seem trivial to others do matter a lot.
It is always important, Dr. Sairu, like all these 6-7 years or whatever I'm working in palliative care, I've had many such cases. Just like talking to the family, spending that 5-10 minutes goes a long way. Yes, Dr. Shanmuga, you can unmute and ask.
Yes, ma'am, very true. I was also about to talk about the caregiver's perspective. And it's a real big burden on the caregiver also to be a support giver if she or he is the only person. And lots of personal and professional experiences with neighbors, acquaintances whom I have known in my own family, all these things. Sometimes they want to be too independent, the patient, they don't want to tell the others. And it puts a lot of pressure, especially on the spouse or the primary caretaker. It could be the elder daughter or a son who had to carry that burden till the end. I have seen when we share it with the other family members, they were being supportive, at least for the caregiver, it was a great support. So that is a very important part of that I think as medical professionals we should learn. to do that in every aspect of treatment or in patient consultation or care. Thank you.
See, that is why now what we say in the definition itself, palliative care is for the patient and caregiver, patient family. That is why from day one we start when we do introduction of palliative care. So because the surviving person, that's why I gave this example. Same thing, no? In any case you take, the surviving person is going to, surviving person needs emotional support, surviving person needs financial support. That is why we are telling all about this burden on healthcare or the burden on the economic burden on the family, everything. No, the surviving, we have had all of you, like all through it happens, and being wise at those situations, making a correct decision. That's why this risk benefit ratio will work for anything and everything, be it medical decision, economical decision, financial decision. Do always this, and you yourself will find out. In everything it is there. There's nowhere it is not. And think about everything and little bit of spending time. No, okay, when you're seeing patients, you may not find them. I've told this before also. Give some time again. Like all of us, even when you'll have some sessions on communication on how to do this. You will have 2 sessions on communication, but it will be somebody, Kavita has mentioned something one. But if some cases patient doesn't want to share, we cannot counsel relative. Yes,
Madam,
yes. See,
Madam,
again,
one more.
go ahead. Go ahead.
One more chat has come before that from Yash. Confidentiality. If patient doesn't want to inform all, how do we go? Is it not against autonomy? And then from Kavita. But if some cases patient doesn't want to share, we cannot counsel relatives.
See,
Both goes
that's all.
together.
See, these things, no, like you will be dealt with in great detail in communication session. Okay, so you have to. That's all. You will, this confidential, when to share, when not to share, how this, when there is difference between patient and family. Patient doesn't want to inform, or how do we go? Is it not? So that's what you have to sit and talk with the patient separately, talk with the relatives separately, then combine them. That's what we will have extensive discussions in about all this in communication. If some patient that I've answered, if attendant not ready to inform, and if patient is getting deteriorating, then will be doctor responsible to inform. That's what. See, all this we will see a bit more in communication. And there are ways and things, as I say, no, if it is time is your limiting thing, there you may have to speak to them separately and do the same thing on the same day. See, everything, that's why, that is the beauty of our profession. It's not one size fits all. You have to use the appropriate decision making at that point of time to that particular case. So we will have extensive discussions about this in communication. And if not covered in that, I will see 2 things. One is communication, which you will have. And for Dr. Pushpa, in end of life care, we have one session for it. In that, Dr. Pushpa's queries should be clarified on that. No worries. So these 2 will keep in mind. I will keep track and make sure that these happen at that point of time. If nothing else is there, I'll hand it over to Sangeet, please.
Thank you, ma'am. Thank you, Sarah, ma'am, for the wonderful session. Thank you, Radha, ma'am, for facilitating the wonderful session. Thank you all for participating in the program. Thank you. Let's see you in the next session. Bye.
Thank you.
Thank you, Dr. Sairu Philip, also for doing the presentation and taking us through. Thank you, everyone.